day. Before I begin, I would like to thank the organizers of this year's Pain Awareness Week for bringing us together to focus on this important issue. We often say to children before a procedure, it won't hurt much. It's just a little ouch. But for many children, it is so much more than that. It is fear, it is distress, it is trauma that can linger long after the procedure ends. Procedural pain leaves lasting imprints, not only on the body, but also on the mind, and more importantly, on the trust children and families place in us as healthcare providers. Today, I'd like to share why this matters and the strategies we can use to make these moments less painful and more humane. This is not an uncommon scene. In fact, it is becoming too familiar in hospitals. Children restrained, often by multiple adults, just to get through a procedure. And very often the child will be either crying or screaming. In this situation, the child was actually screaming, "I'm going to die, I'm going to die." When children cry during procedures, we often tell ourselves things like this: "It's not that painful. It'll be quicker if we hold them down." And our all-time favorite, "Sikit saja," or "We don't have time to do anything better," or "They won't remember what happened." These phrases we've all heard and maybe even said ourselves. They make the situation easier for us as providers, but they don't change the child's experience. And the truth is, children do remember. Pain in early life is not forgotten. It becomes embedded in the developing nervous system. When children experience repeated painful procedures without relief, their brains actually change. The pathways are rewired, leading to sensitization. This means the child becomes more sensitive to pain in the future. This stress response is heightened, so every future procedure is met with stronger fear and distress. Over time, this doesn't just disappear, it leads to lasting fear, intense anxiety, and what we call pain memories. This is where the body and brain remember pain long after the procedure has ended. When children develop negative pain memories, these memories become powerful predictors of how they will respond to future procedures. A child who remembers a painful injection is far more likely to experience increased distress and higher pain during the next one, even before the needle touches the skin. And we've seen this many times. These memories fuel fear and anxiety, and over time can grow into needle phobia, making even simple healthcare encounters traumatic. And beyond fear, negative pain memories are also a known risk factor for chronic pain later in life. So what might seem like a small moment of pain today can shape how a child experiences healthcare for years to come. When children experience pain and distress during procedures, they lose trust in us as healthcare providers. That loss of trust stays with them. This becomes one of the leading causes of vaccine hesitancy. Children who associate needles with trauma are far more likely to resist vaccinations later in life. It also leads to refusal of care and treatment. Families may delay or avoid bringing their child for follow-ups, simply to avoid more distress. And over time, this can grow into long-term healthcare avoidance, where both children and parents carry fear into adolescence and even into adulthood. So procedural pain is not just about managing a moment of distress, it's about protecting trust in healthcare itself. One of the main reasons procedural pain persists is because it is under-recognized. First, as healthcare providers, we often underestimate children's pain. We may assume they won't remember, or that it's not as severe as pain in adults. Second, fewer than 60% of children receive pain relief during procedures, and it's not distributed equally. The youngest children and neonates, who are the most vulnerable, often receive least. And third, when we ask children themselves, more than half of those in hospitals report experiencing pain during procedures. This is not a rare occurrence. It is a daily reality for many children in our care. In A non-emergency setting, procedural pain is not unpredictable. We know exactly when it will happen, and because of that, we can plan for it and prevent it. We also have effective methods, both pharmacological and non-pharmacological. We now know pretty well what works. And yet, these strategies are not consistently used. Why? Because of limited knowledge, inadequate training, and misconceptions among healthcare providers. The reality is that every missed opportunity deepens children's fear, adds to their trauma, and erodes their trust in us as healthcare providers. This is why it matters. So how do we change this? How do we make procedures less painful and less traumatic for children? These strategies can be grouped into what is known as the 5 P's of procedural pain management: preparation, pharmacological agents, parental presence, positioning, and psychological strategies. Let's start with preparation. One of the most powerful things we can do is to use honest, age-appropriate language. Instead of vague reassurances, we describe the sensation in words children understand, like prick, poke, or sting. Even asking, "What did it feel like for you?" validates their experience. What we should really avoid are phrases like "this won't hurt," or "you're a big boy," or "big kids don't cry." These not only dismiss their feelings, but also break their trust. And trust, once broken, it's very hard to rebuild. We can also give children choices. Do they want to sit on the bed or on the parent's lap? Do they want to watch or look away? Which distraction would they like? Even small choices restore a sense of control. And research tells us this makes a real difference. Honest preparation reduces fear and anxiety, improves coping, leads to better cooperation, fewer restraints, and less behavioral distress. Most importantly, it builds trust and strengthens the child-provider relationship. When it comes to pharmacological options, we don't need to reinvent the wheel. We already have simple, effective strategies. Topical anesthetics like AMLA, which is what we have here, should be applied ahead of time. Ideally at triage or during the initial assessment. By the time the procedure starts, the skin is numb and the child is spared unnecessary pain. For children with moderate to severe pain, intranasal agents like fentanyl are fast, safe, and effective. They give strong pain relief within minutes and, importantly, without the need for IV access. For children under 6 months, oral sucrose is a highly effective option. Just a few drops can reduce both the behavioral and physiological signs of pain in procedures like heel pricks and venipuncture. The evidence is clear. These methods work. The challenge is not availability. It's about making them routine in our daily practice. Sucrose is used for short, painful procedures like heel pricks or venipuncture in neonates and infants. It should be administered 1 to 2 minutes before and continue throughout the procedure. It works best when combined with a pacifier or breastfeeding. Sucrose reduces both the behavioral signs of pain, like crying and grimacing, and the physiological stress response. In that short video, you can actually watch how effective sucrose is. The baby is very settled, even while the procedure is happening. Of course, like any intervention, oral sucrose is only effective when used correctly. Here are some common mistakes to avoid. The first is giving it too late. Sucrose needs to be given 1 to 2 minutes before the procedure, not after it has started, and it is to continue throughout the procedure. The second is underdosing. Another mistake is forgetting non-nutritive sucking, either with a pacifier or with breastfeeding. Sucrose works really well when combined with either this intervention. It's also important to remember that it's really for neonates and young infants. Its effect is limited in older infants or toddlers. And while sucrose is excellent for short, minor procedures, it is not enough for major or prolonged procedures. It should not be relied on as the only pain relief. Finally, giving sucrose via feeding tube does not work. The baby needs to taste it for the effect to happen. The third P is parental presence. We know that children cope so much better when their trusted adult is near. Parents are not just bystanders, they can be a real source of strength. When we affirm and empower parents as active partners, they can help reduce their child's pain and anxiety. This can be as simple as holding a child, offering comfort, or helping with distraction. Yet, we often hear excuses. Parents might get upset, or it makes the child cry more, or even, I feel less comfortable doing procedures with parents watching. But the research is very clear. Parental presence reduces distress, improves cooperation, and builds trust. Trained parents can actively assist with distraction and positioning, and they are less likely to be stressed themselves when they're given a task of helping their child. When parents are excluded, children's anxiety actually increases, making procedures harder, not easier. So instead of pushing parents out, we should be bringing them in to help with procedural pain management. Children of all age groups should have a parent present during painful procedures by default, unless of course the parent is unavailable. However, in older children, especially adolescents, we might want to be more mindful of their privacy. Hence, we can always ask them if they would prefer their parents to be present. Here's how we can empower parents during painful procedures. Invite parents to stay, but don't just say, stay if you want. Offer them a clear role, for example, holding their child or providing distraction. Coach parents briefly before the procedure. Something as simple as hold your child, keep your voice calm can make a big difference. Let parents decide how involved they want to be and respect their comfort level. And importantly, combine parental presence with other strategies like distraction and comfort positioning. When parents are empowered and guided, they become true partners in reducing their child's pain and distress. We are on to our fourth P, which is positioning, or what is often. Let's move to the next P, which is positioning, or what is often called the position of comfort. How we position children during procedures has a huge impact on how they experience pain. Whenever possible, we should let the child choose how they want to be positioned. Giving them this choice restores a sense of control. For many children, being upright, sitting on a parent's lap or in a chair feels less vulnerable than lying flat on the bed. It reduces fear and helps them cope better. For infants, swaddling provides containment and comfort, reducing distress. And across all ages, involving parents in holding or soothing makes procedures far less traumatic. And the research backs this up. Comfort positioning reduces distress, lowers pain scores, improves cooperation, and in babies, it decreases behavioral distress significantly. This is a simple change in practice that can make procedures faster, calmer, and less painful for everyone involved. These are some examples of comfort positioning, which is such a simple but powerful tool. It means placing the child in a secure. These are some examples of comfort positioning, which is such a simple but powerful tool. It means placing the child in a secure, supportive posture during the procedure. Instead of being pinned down, the child is held in a way that reduces stress, helps them feel safe, and actually encourages cooperation. What makes comfort positioning so effective is that it gives children a sense of control, reducing their perceived vulnerability. And when children feel safe, the procedure is smoother for everyone: the child, the parents, and the healthcare team. Unfortunately, there are misconceptions. These are two most common reasons for not adopting comfort positioning during painful procedures. It is thought to be less safe than lying flat and consumes more time. Well, actually, it is safer, as a child who feels secured now is more relaxed, will not struggle as much, and will be more cooperative. Swaddling is one of the simplest and most effective comfort strategies for infants. By snugly wrapping a baby in a thin, breathable blanket, we mimic the security of the womb. This reduces stress, keeps the infant calm, and helps them feel safe during procedures. The key is to wrap the arms and legs securely, but not too tightly. The hips should still be flexible. The fifth and final P is psychological strategies. This is where we use the child's own coping abilities to help reduce their pain and distress. One of the most effective tools we have is distraction, but it has to be age appropriate. For younger children, this might be bubbles, a toy, or singing. For older children, it could be books, videos, or even virtual reality. We can also use relaxation strategies like deep breathing or simply encouraging the child to squeeze a stress ball while counting. These are small, simple interventions, but they make a big difference. And importantly, these approaches don't take more time. In fact, research shows that preparation and distraction actually save time, because managing the aftermath of an unprepared, distressed child takes far longer. So psychological strategies are not just about kindness, they're also practical, efficient, and highly effective. Distraction is a very powerful tool. Distraction is a very powerful tool. By redirecting a child's attention away from the procedure and towards something engaging, we reduce the perception of pain and distress. Different age groups need different tools, as mentioned earlier. The key is to engage both the child and parent in choosing what works best. Distraction can be passive, like watching a video, or active, like blowing bubbles or playing a game. And it's usually the active distractions that are more effective. Most importantly, it should begin a few minutes before the procedure and continue through until it's over. Done well, distraction doesn't just occupy the child, it truly changes their pain experience. When distraction doesn't seem effective, it's usually because of some common mistakes. Sometimes it started too late, when the procedure has already begun. Other times, the tools chosen are not age appropriate, or the child isn't actively engaged. For example, just placing a tablet in front of them without guidance. And one of the biggest errors is assuming one size fits all. Distraction must be personalized. What works for a toddler won't work for a teenager. So when distraction appears not to work, it's often not because the method itself is ineffective, but because it wasn't applied correctly. Another powerful strategy is relaxation. The goal here is to reduce the child's physical tension and emotional stress before and during a procedure. This can be as simple as deep breathing or blowing bubbles. Techniques like belly breathing are especially effective, where a child places a toy or even their own hand on their tummy and practices slow, steady breaths. These methods activate the parasympathetic nervous system, lowering the body's stress response. And when the body is calm, the brain is more open to coping. Relaxation is so simple, low cost, and can be taught very quickly. Yet it can make a huge difference in how children experience painful procedures. So these strategies, the 5 Ps, are not meant to work in isolation. Preparation only works when all the pieces are in place, when language, honesty, and options come together. Parental presence should not be negotiable. It's a principle we must uphold. Every child, every procedure, every time. And psychological strategies, distraction, relaxation, coping skills are what tie everything together, making procedures less frightening and more humane. These aren't luxuries, they are basic standards of care. And when we put them into practice consistently, we don't just reduce pain, we restore dignity, we restore trust, and the safety for our children in our care. So to end, let's be clear. Procedural pain is never just a prick or sikit saja. For a child, it is a big event and it leaves a lasting mark. The pain may only last seconds on the skin, but the memory and the fear can last for years. Procedural pain leaves scars that go far beyond the surface. And the most important point is this: we already have effective pain management strategies. They're not futuristic, they're not expensive, they exist today. What we need is to make them routine practice. Every child deserves this, every procedure, every time. Thank you.